Hello, everyone. Welcome back to Find That Code. I'm Coach Cristin, and this is our Cardiac Cath series from the Coding Corner. If you were with me for part one, we spent our time walking through the heart, working through coronary catheterizations, where the catheter goes in, how to follow the path through the report, and how to tell a selective from non-selective. And today we are using those exact same skills to move south. Welcome to part two, lower extremity caths. Here's why this one matters. Lower extremity reports can look intimidating. Abdominal aortogram with runoff, selective catheterization in the right common iliac, bilateral studies, angioplasty in the middle of a diagnostic exam. But the logic underneath it has not changed one bit. You're still asking where the catheter was, how far out from the trunk it traveled, and whether they're imaging or treating. No pressure to memorize. I want you to walk away with a better understanding of the pattern because the pattern is what's going to carry you through these codes. So let's get into it. We're going to keep it practical. What does the report actually say? How it translates versus selective versus non-selective, where the cath stops and intervention starts. By the end, I want you to feel less intimidating when you see words like runoff or abdominal aortogram with lower extremity study in the note. Fast refresher from part one. So we're all on the same page. First, we care where it went, femoral, radial, whatever. Second, we always follow the path of the catheter through the vessels and not just the big summary sentence at the bottom. And third, selective versus non-selective is still the backbone. Did they stay in the trunk vessel or did they drive that catheter into a named branch? When I say tree, here, think about the abdominal aorta as the trunk of the tree. Off of that trunk, you've got the iliac arteries. Those give you the femoral, then the popliteal, and then you're going to get into the tibial and perineal vessels down the leg. For coding, we care about how many branch points away from the aorta the catheter went. First order is the first big branch off the aorta. Second is the branch off that branch. Third is the one level deeper than that. On the venous side, we're still in the leg, but we're just in a different tree. You'll see deep veins and superficial veins, and they are not just mirror images of the arteries for coding purposes. Venous catheterization lives in a different code set, and the wording in the report can still look different. So you can't just say, oh, this sounds like an SFA, must be second order. You have to respect its own house. In the lower extremities, the selective concept works exactly like we learned before. If they drop the catheter in the abdominal aorta and then shoot pictures without going into a specific named branch, that's non-selective aortic placement. Then, second, they say something like catheter was advanced into the right common iliac or into the right superficial femoral artery. You now are dealing with a selective placement. Look for verbs in the body of the report. Advanced into, selectively engaged, catheterization. This is where you make the call. So, once we have a placement that is selective, the next question is always, how deep did they go? That's vascular order. And I want you to picture it as counting branch points away from the aorta, not memorizing a list of vessel names. First order is that first major branch straight off the aorta. Think common iliac. Second order is a branch off that branch. So external iliac or common femoral coming off the iliac. Third order is one more step away from there, like superficial femoral. And here's the trick that makes it stick. Start at the aorta and walk the catheter's path in the report, counting each time it turns into a named vessel. Every turn is an order. And remember, you code to the highest order reached in the vascular family, not every stop the catheter made along the way. If the report only tells you the final vessel, trace backward and ask yourself how many branches it takes to get there from the aorta, and you'll land on the right order almost every time. Now we have the big coding split. Diagnostic catheterization is imaging focused. They inject the contrast, take runs, maybe do pressure measurements. Intervention is when they use tools to change the anatomy or blood flow. Angioplasty, balloons, stents, thrombectomy devices. If the report documents dilation, deployment, or device names, your coding shifts into the intervention bucket. Minimal crossing over. Sometimes you get a diagnostic cath plus angioplasty attempted, then you code both approximately per guidance, both appropriately per guidance. When you see abdominal aortogram with runoff, think non-selective aortic injection with imaging that follows contrast into the legs. That's different from selectively catheterizing an iliac or femoral. Also, the report's laterality language, unilateral selective iliac versus bilateral runoffs, will change which CPT families and modifiers that you consider. A runoff is essentially a movie of contrast moving down the leg vessels. You can get the same imaging via a non-selective aortic shot or by selectively injecting an iliac or a femoral. Which code you pick hinges on the catheter location at the time of injection, not just phrase runoff alone. Those four mistakes cause the grid the most grief. If you focus on whether the catheter was during the injection, read the exact phrasing for laterality and separate arterial from venous work. You fix most errors quickly this way. Let's put the whole progression into one picture. Start at the top of the abdominal aorta. That is the trunk. And if the catheter just sits there and they shoot pictures, nobody turned into a named branch. So that's going to be a non-selective placement. Nothing about that is order yet. It's simply just the starting line. Now, watch what happens the moment they steer somewhere. The catheter turns off the aorta into the common iliac. That is the first turn, and it makes it a selective study. And that first branch off the trunk is your first order. One turn, first order. Keep going. From the common iliac, they advanced into the external iliac or the common femoral. That is a branch off a branch. So now you're at a second order. Two turns from the aorta, second order. One more step out into the superficial femoral, popliteal, and down into the tibial or perineal vessels. And you're now at the third order. Three turns off the aorta, third order, and beyond. Look at the right side of the diagram and you'll see the venous system counts exactly the same way, but it's off its own trunk. The vena cava is where the trunk is. Iliac veins are the first order, femoral is the next, and so on. Same counting logic, different tree, and different code family. So the whole progression is really one question asked over and over. From the trunk, how many named vessels did the catheter turn into? 0 turns, non-selective. 1 turn, first order, 2, second, 3 or more, third. And remember, you code to the highest order reached in each vascular family, not every stop along the way. We started with lower extremity vascular tree, the abdominal aorta as the trunk, iliacs, femorals, popliteal, and the tibial and perineal vessels running down the leg. Then we walked through the venous side and reminded ourselves that the veins are their own tree with their own code family, so we never copy and paste arterial logic onto a venous report. From there, we nailed down selective versus non-selective. If the catheter sits into the aorta and they shoot pictures, that's non-selective. The moment that the report says advanced into, selectively engaged, or catheterized a named vessel, you're selective. And then it's just counting turns. One branch off the trunk is the first order. A branch off a branch is the second order. One or more step out is that third order. Highest order per vascular family, not every step along the way. We also separated diagnostic catheterization from intervention, imaging and pressure runs versus balloons, stents, and thrombectomy. And we talked through the abdominal aortogram with runoff, where the code hinges on where the catheter was sitting at the time of the injection, not just the word runoff. And we closed on watchouts, catheter location, laterality language, and keeping arterial and venous work in separate buckets. If you take one thing from today, let it be this. Read the report for the catheter's path, count the turns from the trunk, and order will take care of itself. Thank you so much for spending time with me today. If this session made lower extremity coding a click more easy or easier, please give this video a like, hit subscribe, and turn on notifications so you don't miss the next one in the series. Drop your questions in the comments. I read them and I will see you in the future sessions. I'm Coach Cristin, and this has been the Coding Corner Coding Sessions. I'll see you in the next one.